Good afternoon. In the next 15 minutes, I'm going to talk on the pediatric neck lesions. I have nothing to disclose, and I'm going to talk on the approach on the pediatric neck lesions. Then I'm going to discuss some common lesions. Then the issues are all for the pediatric, all the patients. There may be radiation issues, sedation, anesthesia. These are all common. I think they have covered in the previous lecture, so I'm not going to discuss. Then finally, compartment-based, location-based differential diagnosis. So coming to the imaging of the pediatric neck, ultrasound is the modality of choice because there is no radiation. And you can see with an ultrasound, we can say there is a lesion is cystic or solid. We can put the color flow and see the vascularity. We can guide the biopsy. And the problem is that we may not see the deeper areas, or the respiratory tract or the bones may not be seen with the ultrasound. These are all the cons of the ultrasound. MR, again, very good in characterizing the lesion. The problem is longer time and the sedation is required. Third, CT is indicated only in acutely ill patient. We need to rule out any abscess. Otherwise, there is no role in the pediatric neck. Then we have the image-guided biopsies and other imaging modalities. So these are all the imaging techniques. Coming to the approach, we have lesions that are all cystic and solid. So cystic lesions are midline and paramedian cyst on lateral cysts. The midline or the thyroclossal duct cyst and epidermoid, dermoid, everything in the midline. Midline, the paramedians are ranula and the infrahyoid thyroclossal duct cyst. Lateral cyst of bronchial cleft cyst, lymphangiomas, and the vascular malformations. Coming to the solid, either it's a lymph node or non-lymph node solid mass. So this is the presentation that I'm going to do. The common leg lesions are, most of them are congenital lesions. Around 55% are congenital lesions. Bronchial cleft cyst constitute around 18%, thyroclossal ducts again 16%. The inflammatory lesions are 27%. The tumors are less, benign tumors are less, but malignant tumors are slightly more than the benign in the pediatric age group. Lymphomas constitute more. Then we have thyroid and the rhabdomyosarcoma. These are all the lesions that occur in the pediatric neck. And we know the embryology, there may be 6 arches initially develop, then 1 disappear, then ultimately 4 bronchial clefts develop, and the second bronchial arch overgrows the hyoid, everything develops here. So the arches are deep in the 3rd and 4th. And we know that thyroid gland descends from the foramen cecum to the thyroid in the lower neck. Similarly, the thymus is also descends from the mid neck to the mediastinum. So there may be a undescended thymus may be there, and the thymic cyst also there in the neck. So you have to know these embryology, then we can make a confident diagnosis. Coming to the first approach is the midline neck cystic lesions. Most common is the thyroclossal duct cyst. You know, it is on the way from the foramen cecum down to the normal location of thyroid. You can get anywhere the thyroclossal duct cyst occur. So these are all in the tongue, at the anterior and posterior junction of the tongue and the neck. In the infrahyoid neck, it may be absent at 38% of the infrahyoid thyroclossal duct cyst or the paramedian location. And clinically, you can see it is moves with the protrusion of the tongue, and it is typically deep to the strap muscles, whereas the epidermoid and the dermoid are superficial to the strap muscles, where we can differentiate thyroclossal duct cyst from the epidermoid and dermoid. What are the other things we are going to see in the thyroclossal duct cyst? 1% of thyroclossal duct cyst can go for malignant change. So when you see any solid tissue within the cystic lesion which shows vascularity or calcification, then you have to consider there is a papillary carcinoma thyroid developing from the thyroclossal duct cyst. So this is a case of thyroclossal duct cyst which is going for a malignant degeneration. And sometimes in ultrasound there may be an echogenic content, and with the MR if you see a diffusion restriction, then it is infected thyroclossal duct cyst. These are all the complications of the thyroclossal duct cyst. Again, other DDs are epidermoid and the dermoid, which are superficial to the strap muscles. They are very superficial, whereas thyroclossal duct cyst is deep to the strap muscles. And the typical fat lesion, diffusion restriction, pseudo-solid appearance in ultrasound, and the sac of the marble appearance were seen in the dermoid cyst. This is again one another dermoid cyst, examples of fat globules seen within the dermoid cyst. Very rarely you can get a small cyst like this, a suprasternal region, you can get a small dermoid cyst also. Coming to the paramedian cyst, most common is the ranula. Ranula you can see along, it is an elongated cystic lesion. It is not a rounded, it is an elongated, it is seen along the genioglossus muscle. And if it extends to submandibular space, then we call it as a plunking or diving ranula. It is medial to the mylohyoid muscle. So this is a elongated cyst, then you cannot consider other differentials. Coming to the lateral cysts are 4 bronchial club cysts. The type 1 bronchial club cyst, again see around the periauricular region. In the work type 1, it is preauricular along the parotid. The role is to say that you have to show is there any communication with the external auditory canal, because if there isn't communication, then recurrent fistula, sinuses can occur, and you have to completely excise the tract, otherwise you will get recurrence. So this is type 1, and you can see there is a communication to the external auditory canal, so you have to excise the entire tract, otherwise you will get recurrence. So this is the type 1 bronchial club cyst. Type 2 cyst is typically situated slightly lower in the level of the angle of the mandible. There are 4 types based from superficial to the deep. If it is in the superficial location, then it is Bailey 1. Bailey 2 is between the sternocleidomastoid and the submandibular gland. This is Bailey 2 bronchial club cyst. 3 is between the 2 carotids. And Bailey 4 is in the tonsillar fossa if it is deep. So 1, 2, 3, 4 are superficial to deep at the level of the angle of the mandible. And this may communicate with the tonsillar fossa. So you have to look for the communication, any fistulous tract in type 2. The complications are usually the bronchial club cysts are thin walled. If it is thick, that indicates inflammation. And you have to look for the fistulas also. This is type 3. Mostly of them are seen in the mid-neck or in the posterior cervical space. And all the bronchial club cysts should be excised. It should not be, you cannot do IND. If you do IND again, it will come. The treatment is complete excision. Otherwise, it will cause a recurrence. The 4th one is very important. If it is usually associated with the thyroiditis of the superior pole of the left lobe of thyroid. Most commonly, this 4th bronchial club cyst is seen on the left side. And here is one example. The 3rd and 4th bronchial club cyst may communicate with the pyriform sinus. So between the pyriform sinus to the left lobe of thyroid, you get the 4th bronchial club cyst. So there is a sinus here. On barium studies, you can see the contrast is entering into the thyroid tissue, thereby producing recurrent thyroiditis. When you get recurrent thyroiditis or parotitis, you have to consider type 1 and type 4 bronchial club cyst. So coming to the other lateral cystic lesions, here you can see multi-septated lesions here. And contrast, you can see mild septal and peripheral enhancement, and it is extending into multispatial. When you see multi-septated cystic lesion, transspatial, and may show fluid level if there is a venous other combinations. This is a classical lymphangioma. There are two types, maybe macrocystic type if the cyst is more than 1 centimeter, and a microcystic is less than 1 centimeter. Microcystic may be seen as an echogenic because these are all small cyst and shows mild homogeneous enhancement in CT scan also. Coming to other cystic lesions or laryngocele, which mimic thyroglossal duct cyst, but this is typically along the thyroid membrane seen on the lateral aspect of the neck. Here other DDs are for the cystic lesion. This may be an infected second bronchial clefts because it's the level of the angle of mandible. Other DDs for this turbid content may be a necrotic lymph node also. So these are all the possibilities to be considered. This is another cyst that is seen on the left side of the neck, lower neck. It is elongated, longitudinally elongated, cystic lesion here. And in MR, you can see this cyst is reaching the anterior mediastinum and touching the thymus. So this is a thymic cyst. Thymic cyst occur in the neck because embryologically thymus descends from the neck to the mediastinum. So again on the left side, if you see left side, these two lesions coming on the fourth bronchial cleft cyst and the thymic cyst usually on the left side, whereas the fibromatosis of the sternocleidomastoid occurs more on the right side. So this is the case of thymic cyst. Now we move on to the second category. These are all the vascular malformations. There is a very bright T2 hyperintense lesion with multiple phleboliths. When you see a phleboliths with T2 bright areas, then you have to make a diagnosis of developmental venous malformations. In olden days, we tend to call these lesions as hemangiomas. Now hemangiomas are considered as tumors, whereas developmental venous malformations are considered under vascular malformations. So in the vascular malformations, the tumors under benign category, the hemangioma comes under the tumor category, whereas the developmental venous malformation is coming under the vascular malformations. You should know the difference between these two. So the vascular malformations may be slow flow, like venous malformation that I have shown. There is maybe a phlebolith, or a lymphatic malformation, or it may be a various combinations, veno-lymphatic, veno-capillary, all that combinations. Whereas AVM are high flow venous malformations. The tumors are most common are infantile hemangioma and the congenital hemangioma. Congenital hemangiomas are present at birth, whereas infantile hemangiomas are not present at birth but may appear a little later. Here is the one example of multiseptated transspatial lesion. This is a cystic hygroma. These are all the prominent flow voids. These are all vascular malformations. Another, you can see a very large AVM here, a lot of draining of veins and a prominent feeding artery. These are all high flow venous malformations. Coming to the tumors, this is a large homogeneously enhancing mass lesion, T2 hyperintense with prominent flow voids. These are all capillary hemangiomas, may not present at the birth, but you can start seeing after 2 to 3 weeks. It starts growing rapidly in the first year. It may then after 4 years it will start involuting. 50% will involute around 5 years, 70% at 7 years, and 100% at 10th year. So this is an infantile hemangioma. There is no need to hurry to do surgery. Automatically these lesions will resolve spontaneously. So this is a hemangioma, which is a tumor. This shows early intense uniform enhancement, whereas the phleboliths in the developmental venous shows delayed enhancement. That is the difference. And this lymphatic malformation, multiseptated cystic lesion may not show enhancement. Coming to the final solid lesions. Solid lesions, I told lymph nodes. Lymph nodes may, you have to say, either reactive lymph nodes or an lymphadenitis or lymphoma. Usual lymph nodes are less than 13 mm in diameter, and the central hilum will be preserved in an ultrasound. Then it is a reactive or normal lymph node. If you see an inflammation or the capsule is irregular, if you see loss of hilum, If you see a blood flow other than hilum, then these lymph nodes are abnormal. These are all the examples, lymph nodal suppurative lymphadenitis you can see here, the necrotic areas here, and you see the flow also on the periphery of the lesions. Multiple conglomerate lymph nodes with calcification, then you have to consider tuberculosis. If there is no calcification, then you have to consider Kawasaki disease. These are all lymph node abscesses. And these are all the MR shows necrotic lymphadenopathy, necrotizing or suppurative lymphadenitis, which is bright in T2. If this necrotic area is T2 dark, then you have to consider Kikuchi's disease. These are all the retropharyngeal abscess. When you see in retropharyngeal edema, you have to also consider Kawasaki disease, also one of the possibilities. This is a solid mass, hypoechoic mass. Usually hypoechoic mass won't show that much posterior acoustic enhancement. Usually cystic lesion shows enhancement. When a hypoechoic solid mass shows enhancement, you have to consider lymphoma. These are all well-enhancing lymphoma. The PET-CT shows intense FDG avid lesions. Few more cases of, I told, fibromatosis coli, when you had to compare with the opposite sternocleidomastoid muscle, there is a fibrous lesion here. And sometimes you may see a swelling when the patient child cries in the lower neck. These are all the typical thymus, which is giving a starry sky appearance. And in imaging, you can see there is a continuous with the anterior mediasternal thymus, which is the same signal density of the mass what we are seeing during the crying. So this is an ectopic thymus seen in the lower neck. Coming to other solid mass in the pediatric patients, if you see any calcification within the solid mass, then you have to consider neuroblastoma in the appropriate age group. Paraganglioma is another solid tumor that you get in pediatric patients. Here you can see fat-containing lesion, T1 hyperintense areas, and this turned out to be a lipoblastomas. One last case in the upper neck, you may see a common lesion is an rhabdomyosarcoma. Here there is a masticator space lesion that is extending along the foramen ovale to the intracranial compartment, and it also shows metastasis to the bone. So you have to be very careful. The rhabdomyosarcoma is also common next to the lymphomas. I think you know nasopharyngeal angiofibroma is one of the common lesions in the adolescent males, and very important differential sometimes. If you don't see any flow voids, then you have to consider adolescent nasopharyngeal carcinoma, that is called K1 tumor, that also to be considered one of your differential diagnosis. To conclude, ultrasound is the first line of modality and the definite modality of choice for the pediatric neck. We can differentiate cystic versus solid, and we can see the vascularity and the extent also. MR, we have seen the extent will be nicely seen. The CT limited to acute infection to rule out any abscess. And most of the lesions are benign in head and neck. Most of them are congenital that we have seen. And the lesions in the cystic lesions are divided either midline or paramidline or the lateral lesions. And we have specific lesions in specific compartment, or it may be multiple transspatial compartments. And the embryology helps to know some diagnosis in some of these lesions. Then clinically also we have to test, and recurrent lesion in thyroid and parotid, I told you have to consider first and fourth bronchial cleft cyst. And sometimes the congenital lesions can present acute, like within the hemorrhage, or if it is infected, then you can present an acute. Don't consider an acute lesion. This may be a existing congenital lesion which is complicated. So lymphoma again is the most common lesion. And when you see your solid lesions with irregular invasive rapid growth, you always consider the malignancy in the pediatric neck. I thank you for your kind attention. Thank you very much.